Okay, so we are on record, so let me enlarge this. Alright, so right now I'm recording lecture 3, which pertains to chapters 5 and 6 of your textbook. So here we try to discuss a little bit about medical informatics. Medical information used to be fully paper-based industry. I remember those days when I worked managing healthcare data, which was on big fat paper files. Sometimes you pull the file and the files are stacked so tightly that you make a cut on your finger and you need a band-aid right in the file room. And the size of the room needs to expand as you have more and more patient records stored in that particular room and more files stacked on those shelves. So that used to be the case with the healthcare industry. Now, thanks to EMRs and EHRs, things are changing. So in late 1970s and 80s, electronic devices started being used in the medical industry. Oops, what happened? And early reminder reports and other mechanisms were used during this period. So let's go to this idea of computer-based action. McDonald in 1976 made a powerful observation. He said computerized protocols will only be used to the extent that they reflect the physician's actual decision logic. This limitation means that the system described in this paper can only perform informational tasks that can be represented by short deterministic protocols. What does that tell you? This tells that the computer is not a magic wand where you tell everything to the computer. Computer, tell me where is Andromeda Galaxy? And the computer tells you exactly where the Andromeda Galaxy is. You can do that with the present day technology, but the computer cannot take you to the Andromeda Galaxy, right? Unless there's a machine that is used to take you to the Andromeda Galaxy. So therefore, the computer can only do tasks that you teach it to perform, and not everything under the sun. But what that means is the computer can only provide information or decision support that the doctor whose knowledge has been used to develop the decision support knowledge base is going to be the limitation. For example, if I don't know anything, if I'm a doctor, I don't know anything about malaria, and I cannot tell the computer, or I cannot build a knowledge base on malaria when I myself do not know much about malaria. So my limitation of knowing or not knowing about malaria creates a limitation on that decision support system. So the decision support system can only be as good as me, because I am the one who is building the knowledge base of the decision support system. So this is a very important concept for people to understand. Registrative medical record system was, I hope I'm pronouncing it right, forgive me if I'm not. RMRS is one of the EHRs, the earliest EHRs that were used, and it was used on 1.3 million patients, so many records and all that stuff. It turns out there were some positive effects. Physicians ordered fewer lab tests, nearly $900 was saved per admission. Overall, it saved $3 million per year, demonstrated capability to decrease errors of omission, etc., etc. So when this successfully tested and implemented computer-based system or decision support system was put into place, they saw some positive effects which helped them come up with better or more decision support from computers. Expected future enhancements was, inclusion of natural language processing, inclusion of public health decision support, satisfying meaningful. criteria for meaningful use of health records. These are some of the things that the industry is looking for in today's decision support systems in healthcare. So now we look into computerized prior order entry, or CPOE. What is CPOE? CPOE is, if I'm a doctor and I enter information on a patient that this particular patient is diagnosed with bronchitis, and because he's diagnosed with bronchitis, he needs to take so much dose of azithromycin and so much dose of prednisone and so much dose of cough syrup every day. I put it down into the computer system. The computer system takes that information, creates a RFID code, a barcode, and that code is transmitted to the pharmacist's office, where the pharmacist's computer deciphers that code and decodes that code into the prescription and the dosage, and the drugs are dispensed to the patient. So CPOE is commonly used in hospitals. It's a great thing to do because we know about the handwriting problem of doctors and how badly they can write some prescription for patients, and how badly some pharmacists can read those paper-based handwritten prescriptions. Also, verbal prescriptions could also be a problem, because I may say prednisone and the person may hear something else because there's a transmission line problem, or maybe there's a hearing problem on the other side, or maybe I have tongue ulcer and I cannot speak properly. That is the case with me when I'm recording lectures at times. Fortunately, today is not that day. So computerized provider order entry, you have user information going into different servers used for different purposes. Finally, it goes into a clinical database where you have data sets of physician orders, lab results, the workflows, and then are rule engines that for this particular drug, it can't be more than this particular dosage, etc., etc., goes to subscribers. And that could be a red flag pulled because the person has allergy to a sulfur medicine, and the physician is prescribing sulfur medicine. So boom, or maybe the person is diabetic and the cough syrup has a lot of sugar in it. You can't prescribe a cough syrup that has a lot of sugar in it to a diabetic patient. Come on, you can't do that. So those things, the alerts are created for those particular purposes. Here's another, a screenshot of computerized provider order entry. You could see over here the name of the patient, the age, whether the patient is male or female, was seen when, dosage prescribed, frequency, PO means oral through the mouth, or some other means of taking medicine. Could be an eye drop, should be dripped on the eye, things like that. So your prescription has the medicine name, the dosage, the frequency of taking that medicine, and also the method in which the medicine has to be taken by the patient. Laboratory related decision support is also there. For example, the lab test results have to be transmitted electronically in a particular format, and that particular lab test result has to be stored on the physician side. There should not be any lack of information. For example, there will be some observations made at the laboratory, and those observations should not be lost when that information is transmitted to the doctor's or the physician's computer. There's also radiology decision support system available these days. All these decision support systems, they work on the idea of knowledge base. That's why in this course we will be discussing about XML, about RDF, RDFS, ontologies, different ways of developing knowledge structures, etc., etc. what the physician or the end user sees is this nice graphical user interface. But beyond this graphical user interface, behind this graphical user interface, there's a very strong and powerful and a complex system working. And they don't see that, but it is important for you guys to know about it and know some of the fundamentals of that complex system and how it works. So these days we have this idea of personal health record, PHR. A personal health record, as defined by healthit.gov, is an electronic application used by patients to maintain and manage their health information in a private, secure, and confidential environment. So if I was diagnosed with malaria 10 years back, and then I have a history of asthma, and then I have a family history of diabetes, all that is stored. And then how many times did I go to the doctor, how many times I was diagnosed with this particular disease, how many times did the doctor prescribe this particular medicine in these doses, all that is stored in personal health records. So the idea of personal health record is when I go to a physician, I take all that information on me, and when I give it to the physician can say, aha, this person was diagnosed with this particular disease those many times, and has a history of influenza, has a history of tuberculosis, etc., etc. So then it is easier for the physician to make a decision on what you are going through at this present moment, or in other words, if I have to say, it's easy for the physician to make the diagnosis on the patient. So personal health records are managed by the patients, can include information from varieties of sources. It could be lab results, it could be diagnosis, it could be 100 different things, but all pertaining to that particular patient. Separate from and they do not replace any legal record of any healthcare provider. Are distinct from portals that simply allow patients to view provider information or communicate with the providers. What does that mean is you had a doctor in California, and the doctor in California, you like that doctor very much, and you had frequent visits to the doctor whenever you are sick, and you have all the information on what you are diagnosed with from that particular doctor. Now it turns out that you got a nicer job in New York, and you moved to New York, and you have a new doctor. You don't know whether this doctor is likable or not, but you have to provide all this old information on your health to this new doctor. And how can you do? One of the ways of doing it is providing access to personal health record to the new doctor. So this is the advantage of having personal health records. Also these days we use things called smart forms. Long time back when I used to enter some data for disease center, the electronic forms were so smart that if I say that in one place the person is having dementia and the other place the person is perfectly fine, the form would pull up an error and say there is a problem, and the problem is you are saying something here and you are saying something elsewhere. So that's a smart form. Or smart forms do calculations on their own and things like that, dynamically display content, and those type of things. So a smart form is an electronic form used by customer, staff, and partners to apply for products and services. Smart forms can also pull information from knowledge base systems. One example I can give you is if you are doing an ICD-10 code generator, and there are more ICD-10 codes coming in this year from on your ICD-10 code book, and then your knowledge base system, which is your ICD-10 code generator, has to pick up on those new codes and be able to use those new codes. So, and then your smart form can display those newer codes as well. So this is the idea behind smart forms. The idea behind smart forms is dynamism, number one. The other thing is to be able to extract processing or have processing done on the client side. For example, if you're doing a JavaScript or a VB script, the processing is done on the client side. But sometimes the processing need not be done on the client side, could be done on the server side as well, using Python and using JSP and other technologies. So that's the idea behind smart forms. Okay, so that ends my lecture for chapter 3, not chapter 3, sorry, lecture 3, chapters pertaining to lecture 3. And I hope you understood something out of it. Thank you.